Hello, and welcome to Wish Talks, a video interview series where we learn more about the Wish Revolution and what our collaborators are doing in response to the COVID-19 pandemic. My name is Kenny Murillo, and I'm a research associate at the Center for Global Women's Health Technologies at Duke University Pratt School of Engineering. Today, we have the fortune of having two key figures in the Wish Revolution, Dr. Diana Silimperi and Dr. Megan Huchko. Dr. Silimperi is a visiting professor of the practice of global health at Duke University. She is also an international public health pediatrician, epidemiologist, and global health leader. Dr. Huchko is a professor of obstetrics and gynecology and global health at Duke University. She is also the director of the Center for Global Reproductive Health, and she specializes in cervical cancer prevention through her clinical work and through her global women's health research. Thank you so much to both of you for being here today. I'd like to start off by asking, how are you doing, and how have you seen health inequities develop during the pandemic, and how do you think they will persist as a result of this pandemic?
Maybe I'll start, Megan, on the broader picture, if that's okay. So one of the things, I'm going to use a very simple example, but I think the most important thing that is there is already this enormous backdrop of inequities in terms of access to health, health care, and health practices that was largely, but not exclusively, based on income, on wealth disparities, if you will, that often mirrored in the context of having access to quality health care. But let me look at a very basic example here, and that is the practice that we're all putting forward in terms of preventing the spread of the virus, which is good hand washing. Right? Good hand washing needs water, needs soap. But in fact, probably over 2 billion people in the world today lack access to that kind of readily available water. So in the construct of low and middle income countries, or even the low income in more developed countries, in fact, access to water in order to wash their hands, much less soap, is a major issue that is having a disproportionate impact, obviously, on their ability to prevent the spread of this infection. Likewise, if you look at the other most powerful intervention that we have for this pandemic, it's physical distancing. But if, in fact, you are living in a refugee camp, or you're living in an urban slum, or you're living in a tenement with multiple generations in one room or in a very small limited space, literally, it's impossible to practice physical distancing. So our two most powerful interventions globally, in fact, are not going to be possible in the most disadvantaged, the most vulnerable populations. And so the inequity of even protecting yourself from the pandemic is enormous.
Huchko?
Yeah, no, I agree that the virus has done a very powerful job of highlighting the inequities that already exist. I think for many people in this country, looking at the soaring unemployment rate really has illustrated how many people don't have the luxury of staying at home that many of us are complaining about, that we're, stuck at home with our families. We can't carry out our normal daily activities. We have to homeschool our children. And yet, there are families who don't have the option to do that because they're either considered essential workers, or staying at home means that they'll lose their job, or they have lost their job and their income. Their kids may not have access to the technology to be able to do the distance learning. They may not be able to supervise that with their kids. So even within sort of the social structures, social spheres that we're moving around in, we can see this in a way that has really kind of been shielded from much of the American public in the past. And, some of these issues with the lack of ability to physically distance that you're describing, Diana, in tenements or, slums, the lack of access to clean water. I think people have always thought of, or many people have thought of global health as something that happens there. And then we have what happens here in the United States. And I think one of the things that the virus has shown is that, we have very strong inequities that are leading to poor health outcomes for the entire society in the United States. We have them here, as well demarcated as we have, as they are in many low and middle income countries.
Yeah, absolutely. I agree with you more. And it does play out both in the inner cities as well as the rural communities in the US. I mean, the lack of broadband width, for example, in many rural communities in the US is extremely limiting the children's ability to continue learning. And I think that that's an issue in the US, and it's an issue globally, obviously, again, with the more vulnerable populations not having the ability for any type of remote learning, even basic learning. And I think it plays out as well on the nutritional side of things as well, that you mentioned. I mean, so again, in the US and overseas, as household incomes are affected and food supply chains are affected, again, the rural or urban poor in the US already had a scarcity of fresh vegetables, for example, food deserts in the US, but certainly internationally, again, in the low middle income countries, and most definitely in the so-called group of fragile states, the issue of malnutrition and or overt famine in some cases, South Sudan are really a major issue. And these are effects that are going to continue, whether you're talking about nutrition or the lack of learning. To your point, to your good point, Megan, I mean, these are going to continue beyond the pandemic. You don't simply wake up and make up for those losses that are occurring now over a period of time. I think the other issue has to do with just really good access to quality care. And again, even in the US and rural communities, many of them, and you all know that I'm living now in one of them, we don't have a local hospital. We have to go a county or two over to get to a hospital. And so even in the US, there's issues when one needs the appropriate care for this pandemic, will it in fact be accessible? And that's, of course, exacerbated in the low and middle income countries, which probably did not have, in many cases, the most effective system initially. Again, certainly in those fragile states, most of them lacked appropriate hospital care in terms of providers and or supplies. Even in the best of times, they required external assistance. All of those, or many of those, venues for assistance, much less the supply chains, have been severely disrupted with the pandemic. So the ramifications on the inequities in the low and middle income countries, the inequities in the context of our own people in the United States, are enormous.
What both of you just said really highlights how privileged communities here in the Triangle in North Carolina, having access to good, clean running water, soap, and things that we don't really think about because we take for granted. We're generally thinking about how we're going to get those face masks, right? So we can go out into the public and have that sense of security that we may not become infected. But when we think about communities in rural areas and obviously abroad, the picture looks completely different. A question for you, Dr. Huchko: how do you see sexual and reproductive health care needs being met here and in low to middle income countries?
So at Duke, we've made a lot of changes to the way that we deliver healthcare on the GYN side. So many of the all of the women who were scheduled for surgery, cases have been reviewed, and we've looked at the risk category, and women who weren't at highest risk, their cases were deferred until after the COVID scare. And then for people who needed to come see us in the clinic, we've tried to minimize the inpatient access or inpatient visits. I wouldn't say access. We've tried to minimize the inpatient visits while still ensuring that women can get their needs met. So women who have time-sensitive issues or things that might be urgent, we will make accommodations to see them in person. We have trained almost all the providers to do telemedicine, and we've offered most patients, unless they seem like they have an emergency or an urgent issue. We don't ever want things to get to emergency. We've tried to do a visit either by phone or by video. On the OB side, the high-risk OB team at Duke are some of the leaders in infectious disease and pregnancy, and they've helped rewrite some of the protocols for antenatal care so women can get seen, throughout their pregnancy and get a check-in postpartum, but converted as many of those visits as possible to telephone calls. And then we've created a separate clinic for women who test positive for COVID, so they can come and get taken care of in person in pregnancy if they need to. We've really been spared a lot of the numbers of women in pregnancy who have COVID here, which has been great, but we want to make sure that women aren't afraid to come into the hospital or afraid to get their antenatal care because they're afraid of COVID. So I think one of the best things we've done is created an education pamphlet for women visiting our clinics, whether they're pregnant or not pregnant, what to expect when they come in, what are the safety precautions we're taking, and what are some of the things that women can do themselves to protect themselves. And then starting over the next few weeks, we'll be starting to open up the clinic to ensure that we get women in for the non-urgent but important visits like preventive care and the screenings and physical exams. So I think that Duke has shown an incredible amount of leadership, but put in a ton of time, energy, and resources into this that many health systems and resource limited settings don't have. So my colleagues on the ground, really, they've talked about having seen non-urgent healthcare settings close due to the stay-at-home orders and the mitigation strategies for COVID. So, I think that different countries have shown different priorities in what they identify as urgent versus non-urgent. And unfortunately, there have been, several reports that show that family planning clinics that provide early pregnancy care or abortion services where they're legal, those have been deemed to be non-urgent. And so, missing out on much needed birth control, especially, in situations where one is sheltered in place at home, can lead to dire consequences for the women if they are not in a position to have a pregnancy or don't want to become pregnant. And of course, abortion is a very time-sensitive procedure, and the American College of OBGYN has come out with a statement saying that it should not be deferred for COVID. It should be considered an urgent procedure or time-sensitive. And so a lot of institutions have put that in place, but sadly we've seen some states who have used this pandemic as a political tool to reduce women's access to a key healthcare service. So I was telling Diana that at the beginning, when we first started hearing about the pandemic, I sort of said, well, maybe we should step back, and the focus should really be on pandemic control and issues directly related to the pandemic. But unfortunately, really quickly, it has become evident that access to women's healthcare and reproductive healthcare seem like they have been either politicized or disproportionately negatively impacted by some of the restrictions on COVID. And so this is not a time to lay off thinking about reproductive health and reproductive healthcare services. It's time to really ensure that these services can continue in the setting of major societal shifts where they're happening.
Thanks. That was really a great explanation of what's happening here and overseas. I'll add a little bit to that. First, if I will, and then maybe shift to more the pediatric side of things, the next step. But I'll reflect initially on living now in rural Carolina and being involved really with that kind of the local response to the pandemic as well. Then I'd like to shift internationally again and focus more on low middle income countries in particular, and how the pandemic is affecting child health. And adolescent health to some extent. But I want to pick up first on what you just said, because I think linked with the infectious pandemic, if you will, is a second pandemic that's it's already happening. We're seeing it here in rural Carolina. I know there's evidence overseas, and it does directly impact women, and that's the mental health pandemic. And that mental health pandemic has many different faces, but one of them certainly has the face of women. Both women potentially in postpartum depressions and not necessarily being able to access care, but also in the context of domestic violence. and the stressors that come with loss of income, family structure changes, and the stay in place that in many places, in many countries and the U.S. are still very much the main intervention to stop the spread. So we are seeing a rise in those things here in the rural Carolinas, and I'm sure that that's a major effect of this pandemic that influences families and women in particular globally. And unfortunately, there are really not effective, again, very limited mental health services in many countries, even in the best of times, and even in the United States. That is frankly still one of our weak areas, I think, in terms of the broader health system response. So I just wanted to put that out there as another element that's particularly important to women and children. The other thing I was going to say that you mentioned in the context of women seeking care, and the fact that family planning has actually not been seen as an essential service in many places, including in the US. And we're seeing the same thing, that in fact, the funds to maintain health, small health department services, including family planning, may in fact be jeopardized with this pandemic. And that's not necessarily seen as a top priority. So that's again happening here at home as well. And secondarily, I think the issue of seeking care or being afraid to seek care that you noted is happening in some cases overseas. I'll come back to that around children, but I will say again, it's even happening here in rural Carolina. So one of the things we're trying to do with the services being limited at, in the primary healthcare setting, to make sure that people know that if they need care, they still need to call a physician and make sure that they interface with the health system and not just stay at home and get sicker, right? And whether it's from a flu or symptoms that could be consistent with COVID or earlier in the season flu or other really essential health care, because I think getting that message out is very important, that our essential health services are continuing, albeit safely, as you've described, that the Duke system in particular has put a lot of attention towards assuring. So let me skip a minute now, if I may, over to the pediatric side of things. And I wanted to say that fortunately, we, as you're probably aware, that right now, at least the evidence is that there's less of a direct impact of the virus on children and adolescents, neonate being an exception there. But certainly for children and adolescents, they get the virus, but they are not getting severely ill for the most part, unless there's an underlying condition. Saying that, the epidemiology is still in play. So we're still really, understanding how this epidemic or this pandemic affects different populations. But in general, the evidence to date seems that the direct impact of the infection on children and adolescent mortality appears to be more limited. But it's the indirect effects from the pandemic that will, in fact, add up to the excess mortality in children. And that's something that we've seen before as well from previous pandemics. Probably the best studied was the West African Ebola and to some extent SARS. That it's the indirect effects, and by that I mean the breakdown in medical supply chains, the lack of providers, whether they get transitioned or moved to other places or they get sick themselves, so the actual medical personnel are lessened, and obviously the whole infrastructure of primary healthcare, much less hospitals, is threatened. But the secondary or the tertiary side of that, I guess, is also that people fear to go to the facility. They say, well, that's where you go to die, right? I mean, and literally, it is true in some cases, obviously, but it means that there's a fear factor that keeps people, and in particular, people who have sick children, from taking what they already want to protect their sick child into what they see as a facility that could, in fact, cause in their eyes, cause death. So we really see a change in health-seeking behavior that impacts children's health. We see a change in the preventive services like immunizations that may be decreased or stopped, similar like we're talking about family planning, as programmatic resources are shifted to more directly address the pandemic. In some cases, that includes health personnel being shifted towards hospitals away from primary healthcare systems. and certainly away from preventive services. So the end effect of this is that the diseases that commonly cause the most mortality in children, particularly children under 5, those infectious diseases like malaria, like diarrheal disease, and regular, if you will, pneumonias are not treated. The preventive vaccines are not given. And the excess mortality in malaria or diarrhea disease, for example, in children is enormous. We've seen it in the past, and we're beginning to see those numbers again now. But we really won't have them fully delineated until we're further through the pandemic. But it is certainly a major, major concern. The other side of that is the nutrition that I mentioned earlier. And clearly with the economic consequences, as well as the lack of health system ability to address some of the nutritional needs, these are long-ranging effects on children's health and ultimately their ability to learn and be productive citizens, frankly. And the final piece I'll mention in this context is, in fact, the psychosocial trauma that I noted earlier and the mental health issues. And these affect children just as greatly as they do adults. And we're woefully prepared to address those sorts of things in this country as well as internationally. The numbers are quite astounding. Groups like World Vision and International Rescue Committee have put some of these numbers together, but they're estimating that 30 million children's lives are at risk from these secondary impacts, particularly in those fragile states that I mentioned earlier. And the potentially fatal diseases, particularly from malaria, but also from diseases that are immunizable, like DPT, are really important. So the children, in fact, are not, for the most part, are not going to die directly from COVID, but they are very likely to die from diseases that have preventable and or treatable interventions possible, but they're not going to receive that care.
Incredible points, both of you that brought up. And something that we previously touched on was the politics behind the pandemic. And I would like to follow up with the question, how are local and national policy and decision-making influencing the pandemic response on the ground? And in the USA, how has the politicization of the pandemic affected the ability and decisions of communities to respond to the pandemic?
Maybe I'll jump in first on this one. Well, I think that it's been incredibly tragic, particularly in the United States, where clearly the pandemic has become a political issue that has begun to influence things at all levels. But I certainly can. I'll talk about the U.S. first, but then I'll talk about the same kinds of impacts in other countries. But I do think what's really important is that leaders do set the tone, be they local leaders or an organizational leader or a national leader. One of the things that I think has characterized this pandemic is the incredible amount of information from many different sources, which has led to a profusion of confusion. And the other element is that there's frankly been a lot of disinformation or inaccurate information. And so I think it's very difficult for the average person internationally and definitely in this country to really sort out what are the facts, what are the evidence, what should they do. As a consequence, they often turn to watching the examples of those they respect, which in many cases are leaders, again, at whatever level. And so I want to stress how important leadership's behavior is in this kind of situation. And poor examples can have a major impact on the behaviors of the population that looks to that leader. I see here in the rural areas of North Carolina, again, that same thing, that people are really confused by the numbers. They're confused by forecasting and why these numbers, that are put forward in one forecast don't play out. And so I see actually decisions being made by individuals and by communities, and in some cases by their local leaders to question, in fact, some of the basic interventions, particularly the stay-at-home policy, but specifically in that context because they are also very concerned about socioeconomics. And the poor communities are hit every bit as hard as the larger ones in that context. And in many cases, the relief measures are not going to smaller businesses. They are not reaching them, even if in fact that was the intent. But in that context, I'll bring up also globally that probably the hardest hit is the the informal sector. I just made a new word up, the in-sector formal, the informal sector. And the informal sector is clearly that supplies the well-being and the income for many people, probably the majority of people in low and middle income countries. And yet that sector is totally being decimated by some of the broader political decisions, some of them based on evidence, but when one begins to close borders and restrict movements, obviously it influences not only the formal businesses, but also that informal sector. Without resilience, without a safety network, it's a safety net or network, it's really hard for them. I think that the disenfranchised, the voiceless, if you will, in many societies are increasingly invisible. They lack social media, they lack access, as we said earlier, to other forms of media, but they are still, caught, if you will, within decisions that are made that drastically influence their well-being. One of the things to me that is really positive about the WISH team and the WISH efforts is that we're really focusing on increasing the voices, increasing the accountability and the empowerment of women. And I think that is really important as we look at how policy on a national or local level influences communities, the voice of women and their understanding of those facts, their ability to have access to those facts, their ability to understand how they can protect their health and their families and be empowered to do so. Is what the WISH revolution is about, but I think it really has a very important role, particularly now during this time of the pandemic.
Yeah, I would, I'd build on that. I think that's exactly right. And I would say that we've seen the strongest leadership come from the local level and the individual level. So people who are making the decision to stay at home, to whether it's a shelter-in-place order or they have to, just follow whatever the local regulations are and make the sacrifices for themselves and their family in the service of an epidemic process or an infectious disease process that they may not understand. And I think you're exactly right that they have to have trust in their leadership. And so what's been promising is in the sort of vacuum of strong national leadership on this, we've seen local leaders who have the capacity to understand or the willingness to learn some of the public health practices. I mean, these are not years, they're centuries old practices of public health, of, social isolation, contact tracing, testing. These are just basic public health principles. I mean, in a world that is now accustomed to and dependent on globalization, it's almost an impossible transition that we've seen in many societies around the world. If you look at the statistics about how people's movement within their towns and from town to town or city to city, we've really dramatically changed most people's day-to-day lifestyle. And I think the decisions people are making on an individual or a family level are heroic on a day-to-day basis. And I think that they are coming from leadership that they trust. And so if that doesn't come from, a national level, we're seeing governors step up and learn and make the hard decisions. We're seeing in the private sector, even, employers, the leadership at Duke, for instance, has made some really quick and hard decisions about closing campus early and putting the restrictions on the hospital, making workplace, trying as hard as possible to make workplaces safe while guaranteeing while ensuring that people have the tools to do their job and can keep their job. think that on a national level, there are countries around the world who have done an excellent job in trying to manage the pandemic or the epidemic in their own country. And I think we could, we have these great examples that we can follow. The United States is a very heterogeneous population, and climate is much larger than many of these countries. But I think some of the basic practices that these other leaders are putting into place, which, is trusting their public health advisors, not being afraid to make hard decisions, and showing empathy for their population, and really trying to balance the needs of the society, if we're going to monetize the needs of society, with the potential dangers of reopening too soon or loosening up social restrictions. I think some in our government have said that's an impossible choice. We need to push to open up. But, one, I don't think that the evidence would suggest that opening up early will help our economy in the long run, because we will just see these spikes again in the virus. I think there's excellent thought leadership coming out from multiple institutions around the world that put a step-by-step plan in place, put together that present step-by-step plans for the processes that need to be in place to shorten these stay-at-home orders more quickly. We've seen the plans for contact tracing, for testing, and for ramp-ups in the availability of PPE. So there are things that can be put in place effectively in the absence of an effective treatment or an effective vaccine.
One of the things that I'm experiencing, though, is, and frankly, it's interesting to me, having worked majority of my life in other countries and being this situation in a country besides my own, what I'm experiencing here is that many people, and some of them are quite well-educated people that are living in rural areas, just don't either believe or understand, or what's happening in terms of the world of really policy making, the evidence base, certainly in terms of the numbers and the plans. They're just not believed, or they're not translating to the local population. The local population and their leaders are saying, that's for over there. That's for the urban settings. That's for, and it's a really challenging dilemma right now, I think, in translating those messages that are coming from very seasoned, evidence-based professionals that are helping to guide some of these decisions. But I'm seeing that the translation to the local population is incredibly difficult, to have it make sense and for them to absorb and believe it. One of the things that we're doing locally, therefore, and to your comment earlier, Megan, in terms of you're seeing people step up at all levels overseas and in this country, what we've seen is that there's been a really strong desire at the community level to be engaged, and to in some ways to be empowered, to have some response to this incredibly invisible foe out there. And so having a community response network that reaches out through existing organizations, be they churches or small social groups, to reach their members, has been an important way to both check on people and to monitor them, and to address both the social, psychosocial, emotional elements, but also particularly for the vulnerable elderly or those with comorbidities, but that it's also a way to discuss it, to hear the same thing a couple times and be able to absorb it and understand it in a different way than if you see it on the TV or you see it through the voice of a disembodied professional who has no relationship to you or your family. And so it's really been sobering to me to be part of this in this country, but in an area removed, if you will, from the heartbeat of a lot of those decisions and policymakers. But again, the goodwill of people really stepping up and wanting to learn and reach out to their brethren is really been very powerful. I think is going to make a difference in this particular set of communities.
We feel very grateful for the healthcare providers and workers who are showing up to work, right? They can't stay and work from home. They're at the front lines, and we see them as heroes. And one of the comments that was made that was really striking to me was calling the individual actions as heroic. And I think that a lot of us were feeling really stressed, and it was hard to see silver linings when we're constantly being bombarded in the news, and we don't see the impact that we're having on an individual level. So that was really great to hear. And one last question. Sorry. Actually, I wanted to also share that after this interview, I'm taking my nephew to a doctor's appointment. And this morning, you know, this appointment is way overdue, and I wasn't sure if the clinic was open. I wasn't sure how this was going to work, and I just decided I need to call, because otherwise I'm not gonna know. So I was able to schedule an appointment over the phone, and then it turned into a video appointment. And then the doctor said, you know, I just need to see him in person. And I said, I'm available. Like, what do I do? And after this interview, thankfully, I'm gonna take my nephew. I'm one of his main caretakers, and I'm really glad that I will be able to take him in to get
Good.
seen. But
I'm glad too. I'm glad too.
Thank you. For the pregnant women who are watching this interview, and the parents of children who are, again, you know, trying to find the silver linings, and what words of hope do you have for our viewers?
Well, so medically, they think that unlike the flu, which can impact pregnant women more severely, they don't feel that COVID is particularly more severe among pregnant women. In our setting, we've had women recover well from COVID during pregnancy and then be negative by the time they are ready to deliver. We don't think that there is perinatal transmission, so no vertical transmission between mother and baby. And again, as Diana mentioned, there's misinformation. I also feel like we're in a field of changing information all the time, so it's hard to keep up on the latest data, but those two things have been pretty consistent. And then I think that women should not be afraid to come to the hospital to deliver. In many settings, they're putting in place testing when you enter labor and delivery. Initially, many sites said if you tested positive for COVID-19, you would not be able to have a visitor with you during labor. And I think, as you know, the understanding of the psychological effect of having to labor alone outweighed the potential risk of transmission to the partner or the support person. So that's changed in many settings. Because a lot of settings are testing women everyone universally when they come in for labor, the labor floor is a very safe place to be, because we know exactly, it's not, you know, like when you walk around on the street or in the grocery store, you don't know anyone's status. Here, everyone is wearing masks. Or, you know, when women are in labor, we know that they are negative. So I would say the precautions that health facilities and hospitals have put into place have really ensured that patients are not at increased risk for infection when they come to the hospital.
Yeah, that's fantastic, really. I wish that was true everywhere, equally so, but it's really a major achievement, certainly in this country, and I think in some other countries as well, as they're trying to adopt those practices. But you know, I think that there's kind of some system positives that I believe are happening and will continue afterwards. So if I go kind of to the macro level, I think that there's global scientific collaboration greater and more deeply than I've ever seen during, you know, my 30 plus years of practicing. So I think that's really enormously hopeful, and I believe has and will continue to have really, you know, breakthrough advances that are going to help us more rapidly than ever before be able to address this. It's not going to happen in 1 week, but still, I have a lot of confidence, and the degree, as I said, and the width, if you will, of that collaboration is really impressive. I also think that although in the short term that the primary healthcare system may be weakened, as I said, as maybe people are transferred to other parts of the system, particularly hospitals. But I do think that overall this pandemic actually will end up strengthening that foundation of primary healthcare in this country and overseas. I think that through it and some of the work that we're doing again with the WISH program, that WISH initiative, that path shifting has had to occur in part because of sometimes the more experienced the doctors being shifted to the hospital. So what does have to happen at the community primary healthcare level is being taken up and implemented through community health workers or other sorts of local professionals. So I think that path shifting, which we have done kind of sporadically, is now going to happen more systematically and with a longer term effect. And I think also the shifting into the community and households, such as we're doing with WISH, really in terms of building the not just the engagement, but the accountability and the sense of ownership, if you will, that women have for their own health and their family's health will be even strengthened. So out of this adversity, I think those are some positive things that are coming, as well as the obvious extension and much more effective and broad scale use of various forms of telemed and digital communications for medicine.
Thank you so much to both of you again. This has been an incredible interview. I know personally, I will be calling my sister, who's 37 weeks pregnant, and has been very concerned about this. And I feel so relieved from what I heard from Dr. Huchko and Dr. Silimperi. Thank you so much.
And now just take care of your nephew.
Thanks, Penny.
Thank you.
Thanks.